Hello, Assalamu alaikum, and a very good morning to all of you. I'm Dr. Sanaullah. Today I'm going to discuss the introduction and background of the eras in cardiac surgery. किसमें है इसमें चल रहा है इधर चल रहा है हाँ हाँ वो तो ठीक है लेकिन So basically what was the motive to go for this topic? Last year in Health Asia conference we did total arterial revascularization. That was totally a surgical topic. I wanted to move from the theatre and bring the surgeons, to be very honest, outside the theatre. And the motive was that I noticed few of the faculty members, half of the fellows, and most of the residents doesn't know about the eras, to be very honest. And they might be knowing ABC or the definition of the eras, but they don't know how to initiate, how to implement, or how to proceed with the eras components. यार इसको देख ले काइंडली आप पीछे यही है ना देखिए So basically when I was making the logo for this, to be very honest, the heading that was given was perfecting the surgical journey. So without this, without eras, this remains, your surgery remains imperfect, to be very honest. So just a question, what is a successful cardiovascular surgeon? All of you who are sitting, most of them will agree with this definition. Okay, a successful cardiovascular surgeon should be a man who, when asked to name the three best surgeons in the world, would have difficulty in deciding on the other two. That means he thinks he is the only surgeon, he is performing the best. And why this definition comes from these our surgeons, to be very honest, our competencies, our proficiency, or all the competitions that we are doing that are most of the time are staying within the operation theatres. Like if I quote an example, how many times you have seen a resident competing outside the operation theatre? How many times? Okay, just quote ke they say ke I have seen 100 patients last week into the OPDs. You'll find 0 resident. Or how many times you have seen a resident saying ke last week I have worked in the ICU and I have managed 5, 10 or 7 patients which were critical into the ICU. Almost they will say, okay, no sir, it's very difficult. Rather, I'm saying okay, if you ask some resident during the surgery that please go and see my OPD today, yaar aaj to IMA leni thi, sir ne bhej diya. So I think we think okay, all the thing remain within the operation theatre. I think we have to change from this concept. Okay, it's not true. Even when I was giving the invitations for this seminar, most of the surgeons say, sorry yaar, we are busy in the operation theatres. We have got the operation theatres today. So I think we should change these things for our future endurances. So what is basically the enhanced recovery after surgery? Let's discuss the definition first. It is a patient-centered, evidence-based, multidisciplinary team approach. Multidisciplinary, I mean it's united by the cardiac surgeons, cardiac anesthetist, intensivist, physician assistants. They usually develop pathways and a surgical specialty to reduce the patient's surgical stress response, optimize their physiological function, and facilitate the recovery. So when was ERAS program came into being? It was around 2000 that ERAS was introduced initially into the colorectal surgery, followed by the upper GI surgery, then the thoracic surgery, orthopedic surgery, and gynecology. So it's being standard practice in Europe, you can say, in all the specialties that are being practiced now. And these ERAS programs had drastically proven that they have substantial cutbacks in the length of ICU stay, overall hospital stay, or the blood loss, time to ambulation and complications, and increase in patient satisfaction. So why was ERAS late in cardiac surgery? To be very honest, that was in 2017 basically. The like-minded surgeons and all the cardiac anesthetists, they united together in Boston 2017 to formulate some guidelines for this ERAS for cardiac surgery. And the reason we were late at the time, 15-17 years, because the complexity of the surgery, number one. Number two, definitely, it's the cardiopulmonary bypass, multiple transfusions, prolonged ICU stay, prolonged hospital stay, all these factors contributed that the pathways were very late under these circumstances. So basically the first World Congress that was being carried out was in Stockholm in 2018, and the name was given, that is ERAS, Society for Cardiac Surgery. And later a year in 2019, then there came the recommendations for the ERAS that were published in AATS meeting. So ERAS is not only limited to the intraoperative site. This is basically a pre-operative status, you can say, and the prehabilitation of the patient. We hardly are working on the rehabilitation, but now we should work on the prehabilitation as well. Then comes the intraoperative portion. I have made myself this in the bold letters and underlined it just because this is the portion where most of we people who are sitting in the hall concentrate most. Then come the post-operative patient. But ERAS covers your pre-operative, intra-operative and post-operative measures. And I would say that this is the eye-opening slide for all the people who are sitting in this hall. There's only 20% of the mortalities that occur in the cardiac surgery are within the operation theatre, while the 80% of the mortalities are outside the operation theatre. So that means pre-operatively that is 35% and 45% it is the post-operative status. So how much a flawless, or I would say champion or a great surgeon you are, despite of all this, you can just change the fact that is 20%. 80% is different from what we think. So I just want a humble question from all the people raise a question. That let's suppose there is a question paper that carries 100 marks. You will run after 20 marks, or you will run after the 80 marks. So this is important that we should learn this slide. That most of the mortalities are pre-operative either or the post-operative, not the intraoperative phase. Here comes the infinite monkey theorem. What does it say? It says if you let a monkey, a simple monkey, hit the keys of a typewriter at a random and infinite amount of time, remember that eventually the monkeys will be able to type out the entire work of the Shakespeare. When monkeys can do the entire work of the Shakespeare, that means what we are doing, only concentrating on the operation theatres, we are just like the monkey is doing this. And what to do? So I have heard from my mentors, I can teach surgery to the monkeys. So he wanted to convey message, it's not the surgery where we are concentrating only. So the important thing is not how to operate, when to operate, but the important thing is that when not to operate. So let's see, basically this is a journey. In 1958, you'll be amazed to see this patient carrying a pacemaker. Look at the size of the pacemaker that he is having at that time. This is 1958. Today, in 2024, you can see a patient can carry a pacemaker within the pocket. It is half the size of a palm. So that means that with each time passing, we have to work on it in this, and we have to move just with the environment. And here comes the Nokia CEO. He ended his speech while saying that we didn't do anything wrong, but somehow we lost. This I hear from most of my cardiac surgeons, that I have put 3 grafts, all were functioning well. I have put the valve, that was perfectly fine. I did the echo, everything is normal from the heart side. Then where is the flaw? We have to find out these things, which are the important things. Otherwise, we'll be keeping on crying like the CEO of the Nokia that we have done everything right. So, why RAS is needed in cardiac surgery? Basically, there are few things that I want to mention. Number one is the financial burden. Like if you are giving a 4 centimeter hole into the posterior pericardium, this is one of the recommendation in RAS. Just a 4 centimeter incision decreases the atrial fibrillation to the half. By decreasing atrial fibrillation to the half, definitely what you are doing, you are decreasing a day into the ICU and a day into the total hospital stay of the patient by simple maneuver, that is 4 centimeter into the posterior pericardium. Number 2 is the bigger patient hopes. What do you think? You are in 2024 today. Can you afford your patient remain out of the work for 3 months, like 8 weeks? No, you cannot afford it this time. Then why? How to do? What to do? Then definitely we have to apply these things like RAS so that we can mobilize our patient early and we can send them back home early, and as much as possible we should cut down the total hospital or the ICU stay. More complex patients. Don't you think the patients like my seniors are sitting here, those who were coming in 90s, they were a bit easier patient as compared to today. Why? Because the prevalence of diabetes today in Pakistan is almost number 1. The prevalence of Pakistan diabetes, number 2 is the diffuse disease, and the advent of angioplasty and the advancement of the angioplasty. We are dealing with low ejection fraction of patients with multiple comorbidities. So we have to apply these things to prevent and for the better outcome of the patient. So clinical trials have proven that by implementing RAS in these patients can assist in reducing post-operative complications and cost as well. So that was a statement that was given by Charles Daughter in 1964, that what is the future management of cardiovascular pathology? That has come true. To be very honest, the angiographic catheter can be more than a tool for a diagnostic investigation or observation. Used with imagination, it can become an important surgical instrument. Today you can see that they are doing the coronaries, they have involved into the aortic valve and multiple things. So I mean to say, this is a change. So we have to change ourselves to compete with our competitors in 3 or 4 things. What are those? Definitely number 1 is the cost of the surgery. Number 2 is early mobility, early back to the work, less pain to the patient. If we can do all these things, definitely we can perform better than those guys. So to be very honest, what is the take home message for all this presentation? Just as an introduction is, think of surgery, it's just like a marathon. So if you are going for a marathon, you have seen the athletes do not participate into the marathon only, but they work hard. They work before the athletic competition and they go back and see what are the flaws. So prepare for surgery just as one would prepare for an athletic competition. I know it's not an easy job just to start it in a day or 2. I understand not in a wholesome, but I would quote definitely a little progress each day, like a simple maneuvers by day, and adds up to big results. Thank you very much.